So thank you for coming down and helping me out with this, because I did the talk on party and play, and it was okay, but after doing it, I had tons of questions, and then the other thing that I realized, JP, as we've been chatting, is that if I do a talk just to a black screen, it's not always as good, right? And the storytelling and stuff is much better when I can sort of see an audience and go through that kind of stuff. So what I'm going to do today is I'm going to go through the 20-some minute talk that I gave on Chemsex.
Okay.
And then we're going to stop this, and then we're going to do another recording on questions. And I had tons of questions for you.
Okay.
After I read through the material.
Okay.
On it.
Sounds like a plan.
Yeah. So this was a talk that I gave for this education thing that we do for healthcare providers across Ontario. And in the past, JP and I used to do it together, which would have been great because then you have somebody with lived experience. And I think when I gave the talk, I gave all these qualifiers of me being an imposter. I almost made a joke. It was like I was giving like an EDI talk, but I grew up with like tons of privilege and all that stuff. So what I'm going to talk about for Chemsex is I'm going to share my learning journey. I'm going to talk about the Dave Stuart Chemsex assessment. And Irene, Naroj, I hope that's her pronunciation. She's a nurse practitioner that worked at St. Joe's, and now she's at Women's College with Medify. And she prepared this great document from the Ontario HIV Telementoring Network for their crystal meth think tank. And the thing that the audience is going to get out of today is that you're going to be able to describe key questions in a clinical interview with someone who may engage in Chemsex. You'll be able to develop a Chemsex care plan with a client. And then also, as we're talking about this, you're going to reflect on your current practice and potential ways you can better serve people who party and play in whatever clinical field you're in. And so for me, in terms of Chemsex, I think it was three main people that really helped a lot with my understanding of it and being able to approach and work with patients like this, although I would argue that I'm still a beginner in that approach. Tim Guimond's a psychiatrist. He's a medical director of HQ, which is a place in Toronto where they have an anonymous sexually transmitted infection testing. And with that, they've linked it to psychiatric assessments, psychosocial groups, psychotherapies, trauma treatment, things like that. JP, you're also somebody that's helped me a lot, and I'll talk about that, and I'll also talk a bit about Dave Stuart as well. And so even though I did a fellowship training in addiction, I wasn't seeing many people with Chemsex. And I'm not sure if it's because in medicine it really is opiates and alcohol that we have the best pharmacotherapy for. I wasn't sure if it's that we don't have great psychotherapy available for Chemsex. It's not like you have a Chemsex center that people can call and then show up and get therapy right away. You almost have to search and find it. But whatever it is, it wasn't a big part of my practice. And the people I usually would see would be the people that would become psychotic after they would engage in party and play. And so I had a patient that I was seeing where after a weekend of use, they would need an antipsychotic and a benzodiazepine. Otherwise, they would stay psychotic for a couple days or a few weeks and things like that. And it was fascinating because I can't tell if it was me that was avoiding the conversation or the patient avoiding the conversation, but I never asked what they would do. I never asked, what did you do on crystal? They'd be like, oh, I used again. And I was like, oh, I really just don't want to do it again. Oh, I need this. I'm a little bit psychotic. Oh, I get a little bit sketchy for the week afterwards. The benzos help me sleep. And then it goes away. Usually 3 days is enough. And so I had this person that I was prescribing, 5 or 10 milligrams of olanzapine for every time that they would have a weekend break or getaway or whatever that was. And then I was chatting with Tim, and he was like, oh, what was the guy doing on the weekend? Because I was trying to figure out how to help change the pattern. And I realized I didn't ask. And he was like, Wip, when you see someone who's using crystal, you have to ask about sex. And for some people, more common, men who have sex with men, it's a big part of the partying and sexual lifestyle. And for women, it may be part of the sex trade, right? If their pimp is they're just using it to deal with the sex thing. And then when I started asking those questions, it was a completely different story. You find out that when people started using crystal, it would allow them to be more social, more connected. All of a sudden, this whole social network engaged with them. And then afterwards, it was just different because especially if they got paranoid, they wouldn't feel comfortable. Sometimes you'd hear stories where people would use crystal and they'd be on their own for like 2-3 days just watching porn and masturbating by themselves. And then they just feel like shit for like a week afterwards. And then the medication sometimes helps with the psychosis, then they avoid, and that pattern comes back again. When you started working with us as a peer support worker, a training came up, and Dave Stuart was in Toronto, and the Ontario HIV OHTN network had paid for him to come down, and they reached out to me to say that, hey, do you want to come to the training? But because I couldn't get anyone to cover up my workplace, I asked you to go down and said, well, hey, JP, why don't you go down and why don't you tell me about it when you come back? And when you came back and told me that, I was like, wow, that was fascinating. You talked about the kinds of questions you asked, the kinds of patterns, the time it takes to have a healthy sexual relationship after chemsex, how hard it is to break out of the cycle, and all of those kinds of things. And it was really eye-opening for me. And even though Dave Stuart was the one who came down, he's had phenomenal things to say about him. I don't know why. I almost imagine this like 50, 60-year-old man who's like out of shape and like old and all this kind of stuff. But it's this guy that's really like fit and young and healthy looking that came there as well. And prior to giving this talk, I probably watched I don't know if it's like 6 hours, 8 hours, or 10 hours of his videos online. And I feel we're so lucky to live in this video age where his stuff was published, right, on there, because he has a couple of his workshops, he has a couple of his interviews, and it's just eye-opening to hear him speak. And for this, I'm going to try to embody some of his spirit, but he says this much better than I do. And much better than I ever really could. So he talked a bit at first, about the 60s and how it was a time for sexual liberation. And it was a great time for gay people and gay men, because all of a sudden you had some places you can go and get connected and all that kind of stuff. And it was really quite a special time. And he even said that, around the late 1970s and early 1980s, Mick Jagger and David Bowie were openly bisexual. They're like, absolutely bisexual. This is what I am. And then what happened, as you know, it's the HIV and the AIDS epidemic. And all of a sudden, it wasn't so cool to be gay anymore, right? And all these people who were gay just had all of their friends and loved ones just dying, right? They had all these ones dying. And even if you're not gay, if you had a friend or loved one who was gay, they were dying. And people who didn't die, they were so sick. They were so sick in your death. And I can't even imagine how traumatic that would have been. And then what happened then, at least according to Dave Stuart, was that the gay culture completely went into the underground. And so then it's more in bathrooms, in campsites, in places that aren't necessarily out in the open. And that's where people had to go for it. I think eventually, treatments for HIV and AIDS came, people's viral count were able to get low, all that kind of stuff. And then he describes this syndemic happening around 2005 to 2008. Everything sort of changed at once. So first you have this community where you have certain people that were really traumatized by all the death that was happening then. They had to go through this culture of being completely isolated and not connected. And then that background on top of two new things, right? And so one were the new drugs. So there was crystal meth, there was GHB or GBL in the UK, and there was methadone as well, which is a type of stimulant. So those drugs came around. And if you look at from the 1990s to 2005, very little overdoses and people presenting the emergency of gay men. And then after 2005, it went up a lot. And then the other thing that happened, there was no way to stop this, was the Grindr app. And so all of a sudden, you know, you get off a plane, you're sort of smiling a bit, you know, but you get off a plane.
I'm still stuck on the gay campsites, how the sex went all over to the campsites, but I'm going to let you keep going.
Well, you know, I'm telling somebody else's story, right? Like, this isn't my story, but you
might be misremembering it a little bit, but okay, go on.
Well,
Let's go.
He says it better, and it's authentic.
Well, yes, I don't know of the gay campsite sex, so but parks maybe.
Yeah, maybe like parks or like alleyway, like places where it's not like a common area where it's like fun. It's like done in hiding.
Is it okay if I just kind of back that up a little bit and kind of put that in a little bit of perspective? I think that Dr. Stewart's perspective is obviously point on. He is the guy. He's the go-to guy.
Yep.
We both highly recommend you check out his stuff. We're going to include the links in whatever you're listening or watching this on. But his experience is from being in one of the biggest cities in the world, London, and we're here in one of the biggest city in our country, Toronto. But being gay is not in a metropolitan area is one thing. Being gay in smaller town areas is a completely different thing, right? So I think that anyone who's joining us from a town of less than 1 million people isn't really relating well to some of the things that we're saying. So I just want to put that in perspective, because that sexual revolution never happened in Windsor, Ontario. No disrespect to Windsor, or any smaller town thereof, right?
Yeah, no, that's a great point. And yeah, it is London, so it's a heavy metropolitan area, and the numbers that they were seeing there would be quite high, whereas in the smaller towns it'd be quite less, and it'd probably be a different story.
Well, it's a completely different story. It's not that these things weren't happening, it's just they were happening in a much different way, because, you know, there's still, as we say, the term on the DL or on the down low, right, where somebody's like, somebody's maybe having their sexual revolution, but they also could be married with 2 kids, and the family doesn't know about their sexual revolution happening in their family. So there's a lot of things happening in the shadows, as you've said in their talks, right? Yeah. And that's a reality for our folks. And
great. So I think thanks for clarifying. And I think we always have to be careful, because an experience by one person doesn't represent the experience by the group. And there may be certain trends, but there could be certain uniquenesses in each individual, and so so I just
sorry, I interrupted. So
no, but I think that's important. And the way that he really frames it is that you have this culture that there might have been some kind of trauma. And I would argue, in a small town, it'd be traumatic. It'd be absolutely traumatic to grow up
off the charts.
Yeah, so I think the whole story around the 80s, 90s things around, you have this culture that was traumatic, the people were isolated, alone, and all of a sudden there were new drugs, because new drugs, and the second thing was that there was the grinder kind of app. And he sort of explains it like with the old drugs. With heroin, what do? Heroin, you go inside, you're all about yourself, and you're just like, you just want to exist and and feel numb. With MDMA, it was all about the other person. Oh, I just want to make sure you don't get HIV. I really care about you. I feel so connected. You'll start to like snuggle with like pillows. Like it's just, you're so concerned about the other person because it's an empathomimetic. So it makes you feel this empathy for others. And these new drugs, the crystal meth and the methadone, combined with the GHB, it's all about you. And it's all about me and my stimulation and what I need. Like, yeah, we're having great sex now, but let's make it better. Let's make it better. Let's make it better. Let's get more people. Let's do this kind of stuff that you were sort of telling me that he would say in his training. And it was almost like, because of how powerful the drug were, you could just maintain that high for longer than you could imagine. And you just need more and more and more stimulation. And so you have this new thing where it's not about the other, it's more about yourself. And then the other part is that any city, anywhere in the world, when you get off the plane, before you get off the plane, you're connected to a full community of people.
Absolutely.
Right? A full community of people. Yep. And the people that go through this, they're so in awe about being connected, they don't realize that, hey, I can discuss boundaries, I can discuss this, I can discuss that. And he was saying that, how do we get connected to people? Well, the first person we connect with when we're born, we connect with our mother, because we make eye contact, we see them, we know what it's like to experience care, we can tell if someone's eyes are nonverbal. And all of a sudden you have all these people that are relying on a couple of text messaging, and they're immediately agreeing to have sex with somebody with or without drugs, maybe like hours before they see them. And they can't say that, hey, I'd like to have a conversation first, like to have dinner first, I want to get to know somebody, maybe on the third date we can do that kind of stuff, because they're not taught that stuff. They just took it sort of by storm. And then, unfortunately, for the decade afterwards, and probably still ongoing, that's where all these GHB overdoses were happening in London. People were coming to hospital with those overdoses. And then the sexual transmissions were going up as well. And even when they started their sexual clinic, you know, a lot of these addiction people didn't know about what was happening. But when they started up their sexual, they'd find anytime there was a long weekend, all of a sudden you have 30, 50, 100 people waiting outside their drop-in sex clinic, right? Anytime there was a long weekend or some kind of party or all that kind of stuff. And for him, I think one of his big goals were, well, I guess was twofold. One was to bring in the addiction people into these sexual health clinics. And the second thing was to help the addiction people feel more comfortable approaching this and handling it in their practice. And so, I mean, he really uses the term syndemic. And the website that he has is phenomenal, you know, www.davidstuart.org, Stuart. And there, I think he has links to a film that he did. He has a couple of books there, and it says a little bit about him. And the great thing about it is that there is a Chemsex care plan. There it helps people who are interested. They can click on it and go through a Chemsex care plan. And then also he will discuss, you know, Chemsex first aid, psychosis, jet set triggers, boundaries, GHB diary, risk assessment tool, all that kind of stuff. He, on the websites that he has videos on and online, he has these coaching sessions, and it's just, he does those like role plays, right? But he imagines, okay, say you're a 55-year-old married woman with 2 adult children, and you're living in a rural area like 2 hours outside of London. How do you do a chemsex history? And so he's almost preparing people where it's just so foreign to them how to do it. And he does exactly what you told me, right? So he says he'll say like, you know, like, oh, do you party with drugs with a smile, or do you like to party with drugs, or do you party and play? And just to try to create a space where it's open to talk about it. And once it's open to talk about, he'll ask people, oh, what about your past relationships? When is the last time you had sober sex? And would you be interested in trying it out to be for a period of time? And if you go to the website there and you click on it, it'll ask what your goal is. You know, is your goal abstinence, taking a short break, playing more safely, not too sure. If you click on abstinence, he has like a full sort of page, and basically the end of it is like, let's come up with something more realistic. You know what I mean? Like, he's like, let's just, you know, because it's like this for anything, like alcohol. Otherwise, you have a shitty weekend. What do you do? I'm never going to drink again, right? Like, you have something where you feel like vulnerable, abused, taken advantage of. Be like, fuck that, I'm never going to do that again. But with this doesn't. So he has all these options, and then you click on it, you can see that he was really, really trained in motivational interviewing, right? Because he's designed it so it includes basic addiction, behavioral health principles, you know, on figuring out what the drug does for you, creating a healthier life, avoiding triggers, all that kind of stuff. But he makes sure he knows where you're at, and so if you click abstinence, he'll recommend a shorter period of time. Anytime you pick, whether it's 2 days, 2 months, 6 months, whatever it is, he goes through a bunch of questions. He figures out how confident you are and how important it is that you do it. And if you put a score below 7, he makes you rewind and change the goal, which is exactly what you do in MI, right? I don't know if you've gone to that point yet.
Getting there.
Yeah. So in your training, you'll find that if the importance or the confidence is like under 5 or 4, the goal is probably too hard, right? And you got to simplify it, right? And there was a couple of people we worked with together where you found a way to get them to have 1 hour on a Sunday for dinner, right? And that was the goal, right? But that was realistic. But if you did abstinence, it would have been like, no chance. Why even try? It also has a list of times that figure out what times are you more vulnerable. You know, like is in the morning, is in the evenings with people. What are your common triggers? They differentiate the types of chemsex you have. So are you the kind that you'll have sober chemsex where you just decide to do it? Would you have to drink and have a few drinks first and then go? Do you find that after you have one bump or one use of a stimulant, all of a sudden things change? And then it also has people come up with their own ideas. What would you do differently next time? And what are some of the skills that would be helpful for you? And it's just really nice to see because He actually, like, so for somebody that actually wants to make a change, or a counselor that wants to learn, he actually walks you through what questions you ask, how you ask, and how you do that goal setting. And he's very careful. Like, he's like, because one of the things that he said is that people who are gay have been taught and they've internalized that what they do is wrong. Right? Like being sexually attracted to a man, sexually enjoying certain things is wrong, and people internalize it. And he's very, very careful that, because the whole way we're talking about it now, we're talking like it's a bad thing. You got to stop, you got to stop. But he's very careful. He's like, no, you don't want to make it seem like it's a bad thing. It's not our place to criticize what someone's sexual enjoyment is, what their lifestyle is. And in fact, at these sexual health clinics, most of the people come through don't want to talk about anything. They just want to know if they have an STI and get it treated. Right. That's all they want. They don't want to talk about anything else. And so he really frames it like you sort of start with that, and then sometimes you might be able to ask one or two questions, but you never push it, right? And so with his wording, he doesn't want to frame it like a bad thing. He doesn't want to frame like any kind of sexual liberation as a bad thing. Right. If there's certain problems or harms, he creates a space where you can talk about it. Oh, yes. I've had a couple of, you know what, you've been here for a few weeks, you had 4 or 5 positive tests. Would you like to have less positive tests? Would you like to come here less frequently? Would you like, and then he finds a way to slowly sort of bring it in. And I think, you know, for me, it's one of those things, I mean, I could argue that I don't see many patients like this, but I also think that when I do, I don't have the past experience, I don't have the familiarity, I don't have the comfort. If some of the stuff comes up that it's there, I don't know where to send people to, you know, for it. And I also believe that, you know, if you build it, they will come, right? So when we started these rapid access clinics, or in Toronto, it was just alcohol and opiates, right? That's all we would see. But once you start to open the door, people know they can come, you get more people with cannabis, stimulants, all that kind of stuff. And I have no doubt that if you had something where Chemsex, you know, for help, people might eventually come for it in some way.
I suspect you see a lot of people with Chemsex, but you don't know about it because you're not getting there, right? You're just, as you said in your initial encounters with folks on meth and GHB, it was, you know, you did meth and GHB this weekend. Okay, all right, so how can we help you out? But
we're both colluding, right? Because I don't want to go through it, and they don't want to go through it with me, you know. And they're just like, give me my antipsychotic.
So it's a win-win. It's a win-win just to move on, right?
Yeah, absolutely.
And sometimes the danger of giving that antipsychotic is also, you know, this is where it gets really tricky. Is it a harm reduction thing? Is it because sometimes some of those meds allow people to continue without the psychosis and go a little bit deeper into their into the party, so to speak.
Yeah, so actually that's what would happen to me, right? And so when I would give people antipsychotics, they just party more. Yeah. They just knew they could party instead of having to, because before, people know, some people it's 1 day, sometimes it's 3 days, sometimes it's 1 dose, sometimes it's 1 week. People know there's a certain amount of crystal that makes them psychotic. And when I would give the medication, sometimes they'd just party more. Yep. You know, so.
For some people, it's a number of days that they haven't slept. And for other people, once they've reached that point of psychosis, in my experience, the trip back to that point gets shorter and shorter and shorter. Other times it takes people 6 days to get there, but then once they've gotten there, something kind of breaks a little bit. I don't know what the scientific term of it is, but I see a lot of people that will go back there in 3 hours once they've reached to that point. And that's kind of some of the struggles that I've experienced with, you know, in firsthand, as well as hearing from people as well.
Yeah. So the next things I just wanted to share was, you know, back in 2019, but I think the content's still relevant for today. OHTN had a think tank of people as they're trying to figure out how to help people who use crystal meth. And on the Medify website, METAPHI through Women's College, they actually have a slide deck on this, you know, and I'm just going to cover some of the important points, just so us and the audience have a bit of a...
And we'll include all these links in the description.
Yeah, background around it. So on the think tank, there was the AIDS Committee of Toronto that includes the Spunk and Meth and Sex group. Yeah. I think it's like Adam Bush, and it was Vincent Francoeur. There's Jacob Nagy and Garfield Durant at Black Cap, which is a harm reduction in gay men's outreach. Christopher Haddon at Rainbow Services at CAMH, Diane Griffiths and Jordan Bond at the Gay Sexual Health Men's Alliance, Meredith Frather at Education Services HIV, Frederick Cruzat at Maple Leaf Primary Care Clinic. I don't know if I should be going through.
We'll include all these in the.
Oh yeah, okay. So yeah, we'll share the slide deck because it has all that information. And when they were looking at, they're mainly looking at crystal meth and for gay and bisexual men who have sex with men. You know, and I think nowadays people are a bit more progressive and they will include trans and things like that as well. Maybe actually what I do is I'll just give a couple of the key sort of points in this. And so with this slide deck that maybe I'll just go over at another time, it goes over what crystal does to you, who are the people that are vulnerable, how common it is, and it also talks a bit about what some of the treatments are. And there's not very good pharmacological treatments, and there are some psychotherapies that have some evidence, but they're not readily available in any kind of way at all. And it's something that, I just think it's something that it's very important for healthcare providers, both who work in sexual health clinics and healthcare providers that work in addiction clinics and also probably primary care, to really create a space to talk about this. Because I really feel like our end goal is not just, you know, having ways of sex that have less harm, but if people have some kind of traumas or vulnerabilities to this, we have a way of helping them get care for those other things if or when they choose that they want to.
Yeah, I agree. I think it should be in every one of those. Everyone should have access to this knowledge, right? I think it should be broadly understood, from family practice to an NP in a clinic to, you know, to obviously the sexual health teams and you know, kind of everyone in public health. I mean, everybody needs to, I think, be able to be part of the normalization of this, right? That's how I feel anyway.
Yeah, absolutely. So maybe what we'll do is we'll just stop here.
Okay.
And then we'll go from there. Do you have any questions or comments based on what I've said so far, or do you want to wait and see?
No, I mean not specifically on this. Maybe we'll take it up in the in the Q&A part of this.
Sure, sounds good.